Welcome to our poster, and thank you for your interest. I would like to talk you through how outpatient cervical ripening may reduce the hospital burden during the COVID-19 pandemic. My name is Rodri Saunders, and I am one of the authors of this work along with Dr. Antonio Sard, our presenting author, who is an associate Obgyn professor at the University of Texas Medical Branch at Galveston and is a paid consultant and advisory board member for Medicem. Together, we have developed a health economic model to assess the clinical and economic impact of adopting an outpatient cervical ripening strategy in the United States. The ARRIVE trial reported a significant reduction in caesarean section rates when women were induced at 39 weeks in comparison to expectant management. Increasing the number of women offered elective induction of labour, however, raises the concern of increased resource use due to a longer time spent in the hospital. Combined with the financial burden caused by the COVID-19 pandemic, this may put too much pressure on potentially struggling hospital departments. Adopting an out-of-hospital, or what we call an outpatient strategy, might be an opportunity to decrease hospital resource consumption. The synthetic hygroscopic cervical dilator, Dilapan-S, may facilitate this opportunity because 1. It's indicated for use for cervical ripening prior to induction of labour, and 2. It does not require CTG monitoring during the ripening process. We implemented a standard computational model used in health economics, specifically a cost-consequence model. A cost-consequence model reports both cost and clinical outcomes independently and allows you to decide whether the computed costs or cost savings are worth the expected benefit. We consider costs and benefits from the perspective of a US hospital during the time from admission for induction of labour to post-delivery discharge. In our model, we compared two strategies. 1, the standard of care scenario, where all women were ripened as inpatients, and 2, the outpatient scenario. In the outpatient scenario, only a selection of eligible women were ripened as outpatients, and only these used the synthetic hygroscopic cervical dilator. Inpatients in both scenarios used the vaginal PGE2 insert or the balloon catheter. Our model depends on over 80 input parameters, thus capturing a reasonable level of detail in the induction to birth process. All cost and clinical data were collected by screening for outcomes in articles identified during a structured literature review of the PubMed database. These source articles are reports on large US databases, randomized controlled trials, or meta-analyses wherever possible. We always took the highest level of evidence available given the US setting. We did need to make some assumptions, and in such cases, we use conservative estimates based on real-life examples. Selected clinical and cost inputs are shown in tables 1 and 2. Our analyses found that these items are the main drivers of outcomes in the model. We assessed a hypothetical cohort of women including pregnancies at all risk levels. Only low-risk women were considered eligible for outpatient ripening. The definition of low and high-risk women was taken from the ARRIVE trial. The percentage of primiparis and previous caesarean sections were taken from nationwide US databases. All our calculations were performed using decision trees. This strategy computes outcomes for the average woman. All results are reported as the mean per delivery. Outcomes are valid for any population size. A model always has uncertainty because there is uncertainty in the inputs. Outcomes in published literature generally report uncertainty as the standard deviation or confidence interval. So, to assess whether our results are robust to changing values of the inputs, we performed a probabilistic multivariate sensitivity analysis. This is good modelling practice as defined by ISPOR. We tested 2,000 feasible scenarios, and each time the model inputs were selected at random from the uncertainty range of every single input parameter. In this section, we will take a closer look at the model structure. I will talk you through the pathway we model from top to bottom. Step 1. A pregnant woman is admitted to the hospital with an unfavourable cervix and indicated for induction of labour. It is important to note that we only consider women induced at term for this analysis. Step 2. The woman is given either the vaginal PGE2 insert or the balloon catheter and remains in the hospital, or is given the synthetic hygroscopic cervical dilator and is sent to a private location for cervical ripening. Step 3. The woman's cervical status is assessed. Outpatients return to the hospital for this assessment. If the cervix remains unfavourable, cervical ripening is attempted a second time with the same ripening agent as in the first round. Step 4. Labour occurs either spontaneously, with no further medical intervention, or requires augmentation with oxytocin to encourage contractions. Step 5. Birth occurs vaginally or a caesarean section is required. Here we show the proportions of women ripened with each of the 3 ripening agents in the inpatient, standard of care, and outpatient scenarios. You will see results for 50.9% of eligible low-risk women being ripened in the outpatient setting. This corresponds to 41.4% of the entire population. In this way, we hope to have modelled a large proportion of women admitted to the hospital for induction of labour, by including both high-risk women and those unwilling to leave the hospital. How does the outpatient setting differ from the standard of care? Women spent on average 2.4 hours less time in the hospital when the outpatient setting was made available. This was derived from 1.5 fewer hours in the labour and delivery unit and 0.9 fewer hours in the recovery unit. In addition, the model computes an increased rate of VBACs and a decrease in the rate of caesarean sections. Together, these clinical benefits give us an estimated cost saving of $674 per woman. That is all women, not just those women switched to the outpatient setting. If we compare only those women switched from inpatient to outpatient, then savings increase to $2,042 per woman. To clarify, this is the potential average saving that can be realised by switching one woman from inpatient to outpatient cervical ripening. If you look to the graph on the bottom left, we show you how changing the percentage of low-risk women selected for outpatient ripening from 0% to 100% affects expected cost savings. Note that at all times, high-risk women remain in hospital and are included within the average cost outcomes. You see that the model predicts cost savings from the first outpatient, because the average time saving covers the cost of the synthetic hygroscopic cervical dilator. However, please note that the model performs calculations using the average for a population. It may be that, in practice, the first woman is more expensive due to complications that do not occur in the average case. Therefore, to achieve cost savings, a hospital may need to provide outpatient ripening to more than one woman. Our results were robust to changes in the input parameters. In the sensitivity analyses performed, costs and caesarean section rates were reduced in 91% and VBACs in 96% of the 2,000 feasible scenarios that were tested. What do we draw from this? Well, adopting outpatient cervical ripening for low-risk women is likely to reduce the average delivery cost. Hospitals can begin with few women trying out this outpatient cervical ripening strategy, and if local hospital results are positive, they can expand their offer. This may help to lower the barrier towards deciding to implement the outpatient strategy for your own hospital. During the COVID-19 pandemic, reducing physical contacts is a measure for infection prevention control used worldwide. Keeping women out of the hospital for longer may contribute to fewer contacts, and thus this might be an additional incentive for implementing the outpatient cervical ripening strategy at this time. References for the key parameters presented on this poster are available in the References section. Please note, that the model underlying this work relies on many more references, which cannot all be shown on the poster. However, this work is under peer review, and we hope you can read the full manuscript soon. Thank you for your time, and feel free to contact us if you have any questions.